Welcome to RadClerk Demos. Today we have Matt Swanson who's going to take us through a chest radiograph. Matt?
Yeah, that sounds great. We have a 48-year-old patient with chest pain and dyspnea. Start by identifying the patient with two separate identifiers in order to confirm that we're looking at the right study, which we are. This is on the 6th of June, 2021. Beginning with the technique, I'll use the acronym RIPE-F. So quickly, it looks as though the left clavicle head is overlaying the spinal process, which indicates to me that this is a rightward rotated patient. Um, in regards to field of view, we're missing the right costophrenic angle. Otherwise, technique looks adequate to me. I'll move into pathology and we'll start with ABCDE with airway. Looking at the trachea, I'll make my way down the trachea up until the carina, and you can see that there is an ETT in place, but I'll comment on that later. Moving into the right main stem bronchus, you can see that we have at least a lot of opacity here, and you can make out a clear um, uh, visceral pleural line around the right lung, which indicates to me that we have a large right pneumothorax here. It's also pushing into the midline, so this suggests that we would have a right tension pneumothorax in this lung. Moving into the left main stem bronchus, we can see that we have just a lot of pulmonary edema throughout this entire lung, a lot of diffuse, opacity throughout the lung. And I'd be curious about maybe some kind of, I see that we have a chest tube in place in the left chest wall. So if this was an expanded lung, maybe this is re-expansion pulmonary edema, but likely, there's definitely a lot of edema that's happening in this uh, pulmonary alveolar edema that's happening throughout this lung. Moving into B, bones, with some aggressive windowing and leveling, we'll take a look at each one of the ribs first, from posterior to anterior, all the way around, tracing to see if we have any kinds of fractures, um, just one at a time. Uh, I'm not seeing that we have uh, any fractures for the ribs on the right chest wall. Moving my way through the left chest wall, I'm not seeing any displaced or non-displaced rib fractures there. Looking at the clavicles as well, the clavicles look like they're without any lesions or fractures. Glenohumeral joint looks like they're in place, and it doesn't look like there's any humeral fractures of the neck or the head on either side. Um, Looking for compression fractures in the spine as well. It's more difficult to assess, but nothing is standing out to me. All right, and then moving into C, cardiomediastinal silhouette. I can see that there is a mediastinal shift into the left chest, which is suggestive of the tension pneumothorax of the right chest, but we picked up on that earlier as well. Moving to D for diaphragm, we'll start with the diaphragm that we can see on the left chest. So the left hemithorax, it looks as though there's a sharp costophrenic angle there. The right costophrenic angle is out of view. It's below the field of view here. It looks as though the pneumothorax in this chest is actually pushing air down deep into that costophrenic angle. And I can't visualize that there's any pleural effusion in this space. Moving to E, everything else. So we have an ETT tube that's placed into the um, larynx, and its tip is, if we were to measure it out down to the carina, so right around 2.6. Okay. Yeah, it's difficult to visualize. That's right. Okay. And so if we were to back up, we can see that on the right chest wall, there is a right midline catheter placed, which is ending of a tip in the right subclavian vein. So it looks as though it's appropriately placed. Um, we commented on previously, but there is a left chest tube that's also in the left lateral chest wall. You can see that the tip ends in the apex of the left lung, and that there is also air in the soft tissues of that left lateral chest wall. Looking at the supraclavicular space of the left side of the chest, I don't see that there is any kind of, well, I actually, there's possibly some air that's in that space as well, but very minimal. In summary, this is a 48-year-old patient with chest pain and dyspnea. On AP view, demonstrates right chest or right pneumothorax, suggestive of tension pneumothorax, with a left chest tube in place, and a right midline catheter in place, with the ETT tube appropriately placed as well.
That's a great assessment, and I don't really have anything that I would add to that. Let's go to the priors and the future studies to see what happened before and after. So here we have July 6, 2021 at 4:06 p.m., and we have a prior, so I'll bring them up side by side for you to comment on. So here's what happened on the same day, about 12 hours prior. This is what the patient looked like. And if you could, you don't have to go through the whole thing, but if you could tell us what's the main thing that happened between the early morning that day and then the afternoon on that day.
Yeah, so the main finding is that we did not have a right pneumothorax in the morning, but in the afternoon we had a right pneumothorax with tension.
Mm-hmm.
I can also see that there's possibly blebs in that lung, so I'd be curious if one of those blebs might have popped or, ruptured, causing that pneumothorax to happen.
Mm-hmm. Yeah, they very well might be blebs, something that a CT would definitively come down hard on and tell you about, but that's a really interesting observation that you made there. Let's go to the future study. And this is literally within the hour. We scramble the times, we anonymize the times, but the time between the studies is preserved.
Yeah.
So this actually did happen within the hour. And can you tell me what's the main thing that happened? What are the main things that you see on this study within 60 minutes of this one here?
Yeah, so you can see that the team quickly placed a right chest tube, and the right chest tube is ending at the apex of that right lung. The lung has started to re-expand, and it looks as though it's almost entirely re-expanded to me. But you can see that there's the re-expansion pulmonary edema that's throughout that lung, to be expected afterwards. But there's also the some of the soft tissue air on the right lateral chest wall, as a little bit less than there is on the left lateral chest wall, but there's still that soft tissue free air.
Mm-hmm. That's great. And what else is happening on this radiograph that's life-threatening for this patient?
Yeah, it's staring me right in the face there. A large pneumothorax that's beginning to form. So we have the separation of the parietal and visceral pleura of the lung, and the pneumothorax is back.
Yeah, there's a new pneumothorax there, and maybe it has something to do with whatever changes in pressures that happened as this area re-expanded, and then maybe there's a tamponading effect that happened from all of this tension pneumothorax that was pushing on this, and then that got relaxed maybe, and then that allowed the visceral pleura to separate back out. I'm not exactly sure if that might be a plausible mechanical explanation, but then there's also, it feels like there's also just been increased air in that left flank. Great. So we saw, and then you mentioned re-expansion pulmonary edema. Let's look at before this pneumothorax happened. Let's look at before the pneumothorax happened on the right side. And you can see there was already a diffuse alveolar aerospace opacity, and maybe this was diffuse viral pneumonia. Maybe it was already an element of pulmonary edema or a combination of the two. But it's definitely gotten worse. And this has been the same day, 5 a.m. until roughly 5 p.m. In 12 hours, things got worse. And so I think that re-expansion pulmonary edema possibility is real. Just adding on top of whatever else was going on in the alveolar spaces here. So overall, great work. You started out with this primary study, and you took that apart, and then we went into the patient jacket, looked at the prior and future films to really put a story together on what happened to this patient on that particular day. Nice job, Matt.
Thank you.